So myasthenia gravis is another one of those autoimmune diseases that is going to be commonly tested on your examinations. And in this video, I'm going to make sure we pass through the things that are most likely to show up. And in the process, we shall try to understand the disease as a whole. My name is Benjamin, and this is Made One Pager. Let's get right into it. So myasthenia gravis is a relatively rare autoimmune disorder in which the antibodies are directed against the nicotinic acetylcholine postsynaptic receptors at the neuromuscular junction or skeletal muscles on the. If this doesn't make sense to you, don't worry about it. We are going to understand everything. So the pathophysiology is that we have autoantibodies that are formed. These autoantibodies are going to affect the receptors that are found on the postsynaptic. And this, where two nerves meet, we call that a synapse. The part where the nerve is coming from is the presynaptic. The space in between is the postsynaptic, and is the synaptic left, and the neuron on the other side, where we have the message going, is the postsynaptic. So we have antibodies formed on the postsynaptic. So the pathophysiology is that when you have these antibodies, they are going to cause cross-linking of the acetylcholine receptors. And when they cause cross-linking of the acetylcholine receptors, the receptors are going to be internalized. That is the first thing that is going to happen. The receptors are going to be internalized. They enter into the IVIG outside where they are accessible. Then we have complement activation. When you have antibodies there, the complement system is activated, and this is going to cause membrane attack complex, and this is going to distort the structure of that the postsynaptic membrane. And the structure of it is actually very important to the way the receptors are accessed by the acetylcholine that is released. Then we have a flattening of the junctional folds. Again, when you flatten these junctional folds, you're reducing the surface area over which the receptors can be exposed to acetylcholine. And then also the antibodies are going to decrease the voltage-gated sodium channel density. And this. So the effect of all this is that we have an excitatory postsynaptic potential amplitude that is decreased. The number of receptors that is going to be excited because of the acetylcholine is reduced, and so the potential is reduced. And when that is reduced, remember we have to reach a threshold. We have to have at least very many receptors that are excited so that we have conduction of an impulse. Now we're having these receptors being conducted and being stimulated, and this means our excitatory potential is going to, the end plate potential that we produce is going to be less and less. And when that is less, we're going to have a fatigable weakness, and the decrease in that excitatory potential is known as decrease of the safety, because normally we have a very much more end plate amplitude is way higher than the threshold needed to stimulate nerves. And this is because we want a very small a very small excitement to cause a message to go through. But this is not going to happen in myasthenia gravis. That safety limit is reduced, and therefore we get almost fatigable weakness. So we have the thymus, and the thymus is going to play a role in this. It's thought to play actually a role in this thing because we have thymic hyperplasia, and the thymus has the germinocenters, and this germinocenters is where B cells and T cells are trained. They're trained to recognize soft antigens like this, and like the acetylcholine receptors, and ignore them. But unfortunately, when you have defects in the thymus, the antibodies are going to reach the thymus. They're going to, the T cells and B cells, they're going to go there. They recognize self, but the thymus does not remove them. So we have loss of central tolerance, and that is going to cause a negative selection, and autoreactive T cells are going to prosper. So the common antibodies that we have the anti-acetylcholine receptor antibodies. These are the most common, and they are going to cause complement-mediated postsynaptic damage, often thymoma related. So the thymus is the one that is most of the time are related to these anti-acetylcholine receptor antibodies. And we have the anti-muscle specific kinase antibodies. And these ones are going to affect mostly the bulbar and respiratory muscles, and they're going to cause respiratory weakness. Most of the time, the antibody here is the IgG4 that is going to be involved. And when people have anti-MuSK antibodies, they're going to have a poor pyridostigmine response. And that is because pyridostigmine is supposed to increase the amount of acetylcholine. But the MuSK, the MuSK, is supposed to actually kind of mobilize, cluster these acetylcholine receptors on top of that postsynaptic plate. Now, without MuSK, you cannot bring out the receptor. So even if you increase the amount of acetylcholine without increasing the amount of receptors, you are not going to achieve a good response. Then you have the anti-LRP. This is rare and it pairs. It impairs acetylcholine receptor clustering. So this anti-LRP is going to affect the MuSK. And when you affect the MuSK, you're not going to have acetylcholine receptor clustering. Then you have the seronegative, where we have no detectable antibodies, and it may have low affinity or other neuromuscular junction antibodies. So when you look at the clinical pattern or the clinical features, and this is what is most likely going to be tested. You have a hallmark, which is fatigable weakness, worse at the end of the day, and it's going to improve with rest. And this is a classical picture of so you look at this woman, she has a ptosis here, and that is one of going to be the most common presentations of Myasthenic Gravis. And sometimes ocular ptosis, ocular manifestations are going to be the first manifestations in Myasthenia Gravis. And even sometimes people who have only ocular symptoms after 2 years progress to getting generalized symptoms of Myasthenia Gravis. So ocular symptoms are include ptosis, diplopia, where they have double vision, and while pupils are spared. Then we have the bulbar kind of presentation, where they have dysphagia, they have dysarthria, and they have things like drooling, they have choking because of the paralysis or the bulbar paralysis. Then you have proximal lumbar weakness, whereby the proximal limbs, the parts of the hands that are closest to the body, the feet, are ones that are weak, and we shall see some maneuvers that test out for this proximal limb weakness. And sometimes they have respiratory issues, and that is what we call the myasthenic crisis. So on examinations, they normally have normal sensations, and reflexes are usually reserved, and they have what we call echogandhic bridge. When we look at the clinical maneuvers, sometimes they are told to sustain an up gaze for 60 to 80 seconds. And when they do this, you may see drooping of the eyelid because the eyelid tires, the acetylcholine has reduced. When we have a sustained lateral gaze, they're asked to look to the side for long, and these extraocular muscles are going to get tired or fatigued, and they'll start having a double vision. And then we have arm abduction, where they are trying to put the arms away from the body for around 2 minutes, and then they have fatigue early. Then repeated chair rise, where they are asked to stand and sit many times. The proximal muscles, the thigh muscles, are going to tire very fast, and they're going to have early fatigue. Then they are asked to do a single breath counting, and they have decreased vital capacity. When they're counting from 1 to 50 and they have bulbar paralysis, the dysarthria is going to worsen. Then sustained leg raise is going to cause a weakness appears, and you tell them raise their legs for a while, they're going to have weakness earlier than normal. Then we have some additional Bedside tests like the ice pack test, where when ice pack is placed on the lid, the ptosis is going to decrease, and it's because the ice helps increase the amount of acetylcholine. Then we have the hydrophonium test, and this is now rarely being used, but it is what is commonly tested on examinations. And this is because of the risk of bradycardia. So basically, hydrophonium is a cholinergic. It increases the amount of acetylcholine, and when you give it, it causes rapid improvement of the symptoms, but it is also very transient. It has a short half-life, so the symptoms are going to return soon. So we have a step-by-step diagnostic approach, and what happens is that in step 1, you want to have clinical suspicion that someone has Myasthenia Gravis. That is if they have fatigue, they have ocular symptoms, and the symptoms must be fluctuating. Then in step 2, you do serology, where you check for the acetylcholine receptor antibodies. If they are negative, you go ahead and do the the MuSK antibodies. If they are negative, you want to do the LRP4 antibodies, also best to assess Then step 3 is where you go to the electrodiagnostics. You want to check the nerves themselves using the RNS and SFENG tests. These are basically nerve stimulating tests where you see the effect when you stimulate the nerves. Then a chest CT is going to be mandatory for all patients because we want to rule out a thymoma. Most patients, when they have a thymoma and they undergo a thymectomy, most of the time the symptoms can even improve. Then you want to do thyroid function tests and check for other associated autoimmune diseases because patients who have performed to have a thymoma or these one autoimmune disease may actually be hiding another autoimmune disease. The weakness could also be due to thyroid issues and things like that. So you want to make sure you're not leaving any on that. Then the differentials, these are important to know in examinations because they may want to check you with any of them. So when you have Lamberton-Eaton, this is actually it's called Lamberton-Eaton myasthenic syndrome. This one causes proximal weakness. It causes proximal weakness that improves with activity. Unlike in Myasthenia Gravis, the weakness is going to worsen with activity. And this one is most of the time going to be associated with pyridoplastic manifestation. Someone has small cell lung cancer, they have pyridoplastic syndrome, and then they develop Lambert-Eaton. This is going to be actually common in the elderly. Then botulism, we have botulinum toxin. It's going to cause a descending weakness. That is why it's going to be set on examination. Someone has a descending paralysis and they are going to have autonomic symptoms involved as well as pupils involved. Now, note, in Myasthenia Gravis, pupils are never involved and there is no autonomic symptoms most of the time. Then we have congenital myasthenic syndromes where children are born with this are going to start in childhood. The child is born with a genetic neuromuscular junction defect. And then we have ALS, where we have upper motor neuron and lower motor neuron signs, and ocular muscles are spared early. Unlike in Myasthenia Gravis, where most of the time the ocular muscles actually the first presentation that's going to happen. We have thyroid paralysis and KPS, and this is going to be episodic weakness and ascending symmetric weakness. So when you see ascending symmetric weakness, think about GPS or think about thyroid. So when you look at the management overview, in the symptomatic, we give Pyridostigmine, which is a cholinergic drug. Onset is 30 to 60 minutes and lasts about 3 to 4 hours. And you have to be careful about the cholinergic side effects. Then you have immunotherapy that's going to be first line. You don't want the immune system to continue destroying the receptors. So what you're going to do, you're going to give prednisone. If not, you're going to introduce a steroid-sparing drugs like azathioprine, like mecophenolate, tacrolimus, as well as cyclosporine. So I urge you to reduce on the side effects of doses of these steroids. Then when you have refractory myasthenia gravis, there are some biologic drugs like rituximab that are used. Then you have the targeted biological therapies like eculizumab, that is anti-C5 complement inhibitor. We have ravulizumab, we have FcRn inhibitors, and these are used in refractory acetylcholine receptor positive myasthenia gravis. Then thymectomy is indicated when you have all thymomas, remove the thymoma. If you have generalized acetylcholine receptor positive myasthenia gravis in people less than 65 years, and you have this acetylcholine receptor antibodies to time associated with thymomas, remove their thymus. And if they're supported by the MKTX trial that was done, found that the myasthenia gravis treatment trial that was done and the thymomas was removed, there was improvement in the symptoms. So lastly, we are going to look at the myasthenic crisis, and this is defined as respiratory failure that is requiring intubation, or if we have rapidly declining respiratory parameters in someone with myasthenia gravis. This is an myasthenic crisis, and you want to monitor their phosphato capacity, NAF, as well as bulbar dysfunction. The triggers are going to be very important for you to know. This is someone who has got an infection, they have undergone surgery, they are pregnant, steroid initiation, or they have been given drugs like aminoglycosides. When aminoglycosides are drugs that affect the neuromuscular junction, drugs like magnesium, there's a whole list of drugs that actually can trigger this myasthenia gravis. Then the management is going to be in the ICU, where we do early intubation and we give IVIG or plasmapheresis. We remove these antibodies very fast, and then you give high dose steroids and try to treat the trigger. If it's a drug, stop it. If it's a steroid, kind of look into it. You consider Okay, the important thing is knowing what caused it. So one important thing that you have to know before everything else is you have to be able to differentiate a cholinergic crisis from myasthenic crisis. Cholinergic crisis is going to have meiosis. Myasthenia does not cause anything to the papules, and there are no excess secretions in myasthenia. Whenever you see someone salivating, the sludges, if you remember the mnemonic sludges, if they're having if they're having salivation, they're having those cholinergic symptoms, make sure that you make sure they are not having more of the drug, they have not overdosed the pyridostigmine. So we have come to the end of this video. I hope you have enjoyed. Please do check out the quiz I put in the description of this video. It could be helpful in seeing some of the questions that may be asked. My name is Benjamin. This is Mid One Pager. Till we meet